Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
Hi, I'm Habib Samadi, one of the associate editors of JACC Interventions. I'm at Emory University, and I'm here today with Dr. Jill Jezeram from the Swedish Heart and Vascular Institute in Seattle, and with Dr. Jason Rogers from UC Davis to discuss a very interesting paper that Dr. Jezeram has worked on and will be published in JACC Cardiovascular Interventions soon. The title of her paper is Diagnosis of Secondary Source of Right-to-Left Shunt with Balloon Occlusion of Patent Foramen Ovale and Power M-Mode Transcranial Doppler. So, Dr. Jezeram, tell us a little bit about the background of your paper.
Okay, we have observed and reported in some of our earlier publications a high prevalence of late residual shunt following PFO closure, and we have noted approximately 30 to 40% rate of shunt in 6 to 12 months follow-up using Power M-Mode Transcranial Doppler.
Okay. Now, what are the different ways you can assess right-to-left shunting?
Post-procedurally or even pre-procedurally, we use transcranial Doppler, transthoracic echocardiography, as well as transesophageal echocardiography. In our center, though, what our protocol, though, is using simultaneous transcranial Doppler, also known as TCD, with simultaneous transthoracic echocardiography.
Okay. So I guess there's a 30-40% rate of residual right-to-left shunting 6 to 12 months. And so what was the hypothesis of this current work that you've done?
The hypothesis is that in individuals who have a secondary source of right-to-left shunt diagnosed at the time of PFO closure, then those individuals would be more likely to have late residual shunt in follow-up.
Okay. And how did you go about addressing your hypothesis?
We evaluated 84 subjects for the prevalence of secondary source of shunt by balloon occlusion of the PFO tunnel and confirming that with color flow Doppler and also using intracardiac echocardiography.
Okay. And then how about transcranial Doppler?
During that procedure, we then injected contrast bubbles, and we confirmed presence of embolic tract conductance using transcranial Doppler.
Okay. And what about in follow-up now? What did you find? What percent of patients actually had significant right-to-left shunting during balloon occlusion, and how did they fare in follow-up?
So of the 84 patients that we determined prevalence of a secondary source of shunt, we found that 20% did. And the operational definition that we used was anyone who had greater than 10 embolic tracts on transcranial Doppler. And in terms of late follow-up, we evaluated 66 of those 84. And overall, the entire sample had 40% of some form of residual shunt. 30% had large late residual shunt. When we looked at the two groups independently, those who had secondary source of shunt, we found that those patients had a much higher percentage of persistent shunt, and it was actually 94% versus 44% in the group without secondary source of shunt.
So you're concluding that assessing shunting intraprocedurally has prognostic significance.
This is a preliminary study. Obviously, it's single center. It was powered for the hypothesis, but we do believe, though, that further studies need to be conducted to verify this finding. And we also believe, while we believe that the secondary source of shunt may well be a pulmonary arteriovenous malformation, that should be confirmed with other studies using pulmonary angiography or CT.
Dr. Rogers, please put this in context for us. What are the potential implications of significant secondary forms of shunting, and how does one address that?
Well, Habib, as we know, right-to-left shunting has been implicated in multiple disease states, cryptogenic stroke, migraines, etc., and determining which of those patients have a right to left shunt on the basis of a PFO or some other source, in this case potentially pulmonary AVMs, is very important because obviously if you were to close a PFO in a patient who had a significant pulmonary right to left shunt, they may not receive clinical benefit. So this is a very important paper in that it tries to answer that question, and I believe it does partially answer the question. I will say that the paper identified a much larger percentage of patients with secondary right to left shunt than has been suspected from previous studies. In the study, it was about 20% of patients were thought to potentially have pulmonary AVMs, whereas previous literature would suggest maybe a 5 to 10% prevalence. So I think in moving forward, there may be some important methodologic considerations. For instance, transesophageal echocardiography and pulmonary arteriography were not done in the study to really assess if residual shunting was simply because the device did not occlude the defect, or was it really an intrapulmonary shunt.
Great. Well, thanks very much, and we look forward to your editorial and to your paper and to future work from both of you. Thank you.
Thanks,
Thank you.